Hello, everybody. We are here to cover chapter 11, which is about psychological disorders. So, our learning objectives for today are not exactly in alignment with the book. I left most of it alone, but I took out the details about how the DSM classifies disorders. That's all in your book just fine. You don't need my help with that. And I took a kind of a survey of my in-person class about the disorders that they wanted to know about. And these were them. And these are the ones that we're going to cover in the lecture today. So without further ado, before we can talk about disorders, we need to talk about the framework for them. The medical model is basically the idea that psychological disorders have a biological base. And this might sound obvious, but it was not always obvious. Um, in the not too distant past at all, psychological disorders were pretty much seen by everybody as some sort of personal failure, as something that you could fix just by being tougher or by working harder or whatever it was. And we've moved away from that and much closer to a strict medical perspective, which is basically that mental health disorders are in the same class as any physical disorder and, deserves the same type of attention as any physical disorder would. So this is a vast improvement in many, many ways because it really takes a lot of the stigma off of mental health disorders. However, it's not perfect. So we'll talk about that a little bit as we go on. And anyway, like any physical health disorder, the medical model suggests that we have kind of four components of any illness, and that would be their symptoms, their diagnosis, their etiology, which is causes, and their prognosis, which is the outlook. So, what is a psychological disorder? Your book defines it as a pattern of atypical behavior that results in personal distress or significant impairment in a person's social or occupational functioning. And in fact, this is a pretty accepted definition of psychological disorder. So remember, in order to have a psychological disorder, you need all of these, right? You can't just have some sort of social or occupational functioning problem if there's no impairment or minor impairment or there's no distress, right? You need both components to be in place. So keep that in mind because we'll come back to that. So causes. The different perspectives all have different ideas about the causes of psychological disorders. And the only one up here that isn't necessarily self-evident is psychodynamic. And the bottom line of the psychodynamic perspective is that psychological disorders come from issues in childhood, mainly with your parents. And I think we all know that there is a component to that is accurate. But I think what I want you to get away from this slide is that psychological disorders really pretty much have all of these in them somewhere. And we'll talk about that more in the next few slides. But the bottom line is pretty much everything has you know, if you picture this as a pie chart, some disorders are more biological and less psychodynamic, and some are more behavioral and less cognitive. And but the pie always has these pieces in it. It's just a question of how big the pieces are. Okay, so the diathesis stress model, we've seen this many times before already. And basically, this is the diagram that comes from your book. And I just wanted to stop on this, even though I've given you discussions about this before. And I just want to underline that the bottom line here is that there's kind of always these two components. There's very, very few diseases, even strictly physical diseases, that only have a biological component. So, for example, Down syndrome, right? There's really no environmental stressor in the development of Down syndrome. It is just a chromosomal defect, and that's all. But pretty much every other type of illness, whether it's psychological or physical or whatever it is, has two components, which is some sort of vulnerability, which would be your genetics or some biological process, and environmental stressors. So pretty much always it's going to be a combination of these things. And again, if you think about it as a pie chart, some things are more one and some things are more the other. And, very few things. It's easy to figure out which is which, but there's a few, right? There's a few where the say genetic component is extremely strong. So Huntington's disease comes to mind, which in many ways is a mental health disorder just as much as it is a physical disorder. In Huntington's disease, your body shuts down in such a way that eventually you can no longer move or speak or communicate, but you're still in there, right? It's a pretty horrible disease. And, in Huntington's, the patients, it is, I believe it is a single gene disease, pretty sure it is. And there's a pretty simple genetic test for it. And, if you have a parent with Huntington's disease, it's a very simple, Mendelian genetics. And you can test for it. And if you have the gene, you will develop Huntington's. So, the question, even there, the question is when, right? So if you have kind of a environmental stressor free life, which is not really a thing, but with fewer stressors, then maybe your onset is delayed a little bit. But if you have a bunch of stressors in your life, then maybe it comes more quickly, right? So even in that sort of instance, you have this model at play. So diagnostic labels. So if you think about kind of any label for any mental health disorder, um, we wouldn't have them if they didn't have benefits, but they also come with risks, right? So the benefits are clear. It's intended to be a shorthand between professionals and people with lived experience, where you say, I'm a person living with bipolar disorder or whatever it is. And you would say that to a professional or someone else living with bipolar disorder. And that shorthand is effective in communicating a lot of information. The problem is that a lot of mental health disorders, most I would say, come with stigma. And the stereotyping and assumptions that come along with the labels for mental health disorders sometimes are not worth the benefits, right? And perhaps the bigger issue is that labels come with um, problems for the person who hold them, right? So, if you have been labeled, for example, a person with bipolar disorder, you suddenly go around Googling that and um, coming to conclusions about yourself and about your etiology and your prognosis and your symptoms and all of those things that really can be quite damaging to your sense of self. And this is a real problem, right? Like people have a tendency to limit themselves when they think they are limited. So, if somebody turns to you and says you're a person living with bipolar disorder and therefore you can't do this or that or the other thing, well, that has a tendency to land a whole lot more easily when, you buy into all the negatives of that diagnosis. So there are real risks to being labeled, and there's benefits, but you really have to think it through. If you go forward to become a professional in the mental health field and you have diagnosis privileges, which is not true for everybody, you have to be real careful about how you manage that. Because it's a big responsibility. Okay. So, this is just an example. These are the criteria for major depressive disorder. And the point that I'm trying to make on this slide is that pretty much every mental health disorder has a laundry list of symptoms, and they are mix and match, essentially. So, in this particular case, you need five or more. One of them has to be depressed mood or loss of interest or pleasure. Fine. If I've done the math correctly, that basically means that there's 227 possible different combinations of symptoms that would lead to a diagnosis of major depressive disorder. Well, that's a lot of different um, combinations, right? That's a lot of different presentations. And so even now we're having problems with, I'll go back a second. So we're having a problem with that shorthand, right? When we look at benefits, we're having a problem with that shorthand because now we have 227 different ways that this can look. So you see how labeling can become problematic. All right. So now let's talk about specific mental health disorders. Major depressive disorder is the most common in the United States of all the mental health disorders. In any given year, almost 7% of adults have major depressive disorder. And over lifetime, 20 to 25% of Americans experience diagnosable major depressive disorder. That is a huge amount of people, especially for a disease that carries so much stigma, right? So, the criteria for depressive disorders got changed around a little bit in the most recent version of the DSM. And I just wanted to point out that seasonal affective disorder no longer stands on its own. It is a component of major depressive disorder. Essentially, what seasonal affective disorder is I'm recording this lecture in November. It's been about 2 weeks since the clock changed. And the mood for kind of the general population has changed a lot. And this is normal because when we get fewer hours of daylight, our depressive symptoms increase. We have a nice graph for this coming up. But um, in general, you know, we have to prepare for seasonal affective disorder if we are a person who is already vulnerable to depressive disorders. You just have to prepare for that. There are other kinds of major depressive disorder, including persistent depressive disorder, which used to be called dysthymia. And basically what that means is it goes on at sort of a low level for a very, very long time, years it goes on. Um, I mean, there's a school of thought that there's basically a, depressive personality disorder, and that would be it. But I'm not sure I agree with that. But anyway, that is one way of looking at it. I do really want to emphasize a few things here. Obviously, the one in red, I'm going to emphasize. Depression looks really different across cultures. In many cultures, it does not look anything like sadness. In many cultures, it looks like physical illness. It looks like nausea, stomach problems, or it looks like anger. Um, that sort of thing. But in many, many, many cultures, it comes across as physical complaints. So there's a lot of causes for depressive disorder. You can't put your finger on any one of them. There's just so many, and infinite combinations. But the biological link is really heavy. And so meds are really effective, and there are lots of options. So if you try meds for depressive disorder and they do not work for you, try different meds. There are a lot of options. Ditto goes for side effects, right? So many of the antidepressant medications have a reputation for weight gain and sexual side effects, but not all of them have those side effects. So you can and should talk to your doctor about any side effects that you might be experiencing and see what other medication options are out there for you. Because, eventually, if you stick with it, you're going to find something that works. That being said, some of the most effective treatments are med-free. Oops, you know what? I'm going to skip forward to that. So, treating depression without medication has a number of components to it. There's one that I didn't put on here, which is ECT. If you wanna learn about ECT, it is in the lecture that you can watch on YouTube. It's linked on Canvas. But there's lots of good ways to manage depressive symptoms on your own. I will say that this does not work if they're very severe. You will need medication for that. But if you are experiencing mild symptoms, you can probably do a pretty good job managing them with these components. So if you're interested in these components, you will want to pay very close attention to that lecture. Again, it's next on Canvas for you to watch. So I want to go back because I suppose the slides are a little bit out of order, but there's two really important factors for major depressive disorder, and they really fall into the gender culture category and the daylight category. So I talked about daylight already. This nifty graph really brings this one home, is that, the more light that we have, the much, much lower our depressive symptoms. And, we see it's not quite as stark, but it's still a very reliable pattern that you see that women are much more vulnerable to depressive disorders than men. And if you want to think about what that might be about, um, that is where we go back to cultural determinants of health. So, really what this comes down to is kind of two things. One, that there's a lot of pressure on women to take care of everybody and to be okay, and, make sure everything that is happening the way that it should for the family and the children and the husband and the this and the that. Um, and also, there is a cultural expectation in almost every global culture that women are more emotional. So the symptoms for depression are easier to spot. That's a pretty important factor, but even with that taken out, this difference remains, and that really is about the expectations on women to take care of everybody. All right. So bipolar disorder, the brother to major depressive disorder. So your homework in this module is about somebody with bipolar 1 disorder. It is usually one of the more popular assignments of the semester, so don't miss that. You for bipolar 1, sorry, you do not need depression as a component. However, it's pretty uncommon to see somebody with bipolar disorder who does not have depression. Technically, though, you only need to have one kind of full-on manic episode. And what does that mean? So, when you watch the movies about people with bipolar disorder and they're spending all their money and they're having a lot of indiscriminate sex and all of that, that those kinds of really extreme reckless behaviors or impulsive behaviors are kind of pardon me, the hallmark of bipolar 1. In bipolar 2, you don't need that. As a matter of fact, you can't have that because otherwise you would be diagnosed with bipolar 1. Instead, you need one hypomanic episode, which is basically just like less intense, and you also need a depressive episode. So, there's some issues here. So, hypomanic means the definition is does not cause significant impairment or require hospitalization. Well, remember this. So this was our definition of what a psychological disorder is. And remember, you need all of these. But on the last slide, this is what you saw, right? So it does not cause significant impairment or require hospitalization. And now we're right next to a pattern of, atypical behavior that results in personal distress and causes significant impairment. So, oh, right. So we're back here because the problem here is that we've come up with this psychological disorder that doesn't really meet the criteria of psychological disorder. And so what are the risks and benefits to that? Why are we creating a psychological disorder? And bipolar 2 is fairly new. Um, you know, why are we creating a psychological disorder that by definition doesn't really cause a lot of impairment? We're really leaning hard on this whole personal distress thing, right? And I just, from a personal standpoint, I really have some concerns about this because we're back now to those risks, right? Those risks of stereotyping and assumptions from others, which is especially salient for bipolar disorder, and those self-concept problems, right? Because once you tell somebody that they have bipolar disorder, they're pretty upset most of the time. Once they know what that means, they're pretty upset most of the time. So it can be really problematic to have this particular label put on you because I'm not sure how useful it is to have, and it has a lot of drawbacks. All right, anxiety disorders. So these are basically characterized by being, very distressed, having a lot of persistent fear and anxiety, and in some cases, some very maladaptive behavior. So panic disorders, I think we all kind of understand what that is on a instinctual level. This would be, any kind of panic attack sort of situation. Social anxiety disorder, again, exactly what it sounds like. That's anxiety around crowds or people, or certain types of social situations. Specific phobias, I'm going to talk about that in a second in a little bit more detail. So generalized anxiety disorder is just exactly what it sounds like. It's just being anxious all the time. So I do want to say that anxiety disorders are very responsive to medication, just like depressive disorders are. There are many, many different options, and you should keep switching until you find it. And most of these medications are the same. The exception to that is the short-term meds. So, the benzodiazepines of the world, that's your, Ativan and all of that. Be real careful with those because they are addictive, and they're hard to kick, right? Once you become addicted. So, they have a really important place in anxiety disorders. So, if you're having a panic attack or you are really struggling in a short-term way with something that's going on. So, for example, somebody with, PTSD might be struggling with July 4th. Okay. So that's what your Ativan is really good for, but you don't want to take one every night, right? You know what I'm saying? So we got to be really careful with those, but they do have a very important place in treatment for people with anxiety disorders. I do want to say that the reason why there's a coin on this slide is because anxiety disorders and depressive disorders are basically two sides of the same coin. I personally have never seen anybody who has one and doesn't have the other. So to some degree, or uh, so it's important to think about that, especially in treatment because the meds are the same, right? So, it's interesting to think about how these two disorders really travel together. All right. So I said I would come back to phobias, and here we are. So fear is a natural and adaptive response to a real threat, but a phobia is excessive. It's not rational, and it's about, something that can be quite limiting to your daily functioning, right? If you are, suddenly afraid of sidewalk cracks, you're going to have a really hard time walking to work, for example, right? So, yeah, it has to be irrational. It has to be excessive for it to be a phobia. Okay. So, obsessive compulsive disorder. Um, Obsessions are in your head. Compulsions are things that you do. And um, what I really want to highlight about these is last week we talked about folks with low self-efficacy. And those people with low self-efficacy are really impacted much higher in a much more salient way by obsessive compulsive disorder than those with high self-efficacy. So why would that be? Right. So people with low self-efficacy, really they have a very hard time trusting themselves to correctly do anything, really. And so they do a lot of checking, they're very repetitive, and then they also usually feel like they don't have a lot of tools in their toolbox to manage anxiety, right? If you feel like you cannot um, impact the world, if you aren't in control of anything in your life, then you're probably not going to develop a lot of coping mechanisms because why bother, right? Like why bother to work on things that are going to soothe you if, you believe that all distress is external and you have no way to impact it. So, why develop any of those skills? So, you at that point may develop compulsive behaviors because they're simple. They're simple to develop, and it might feel like the only way that you can manage your distress. So, the intrusive thoughts are not really any different, right? So, if you don't feel like you have any way to manage intrusive thoughts, then, you're going to end up with an obsession, right? And then you might end up with a corresponding compulsion, right? So, okay, eating disorders. So the eating disorders are in your book. There are more of them than this, but I just wanted to underline some of the commonalities in their etiology. And those are basically negative self-image about body weight or shape. It does not have to be about how thin you are, right? So, it can certainly be, I'm not muscular enough, I'm not curvy enough, this part of my body isn't big enough or round enough or soft enough or whatever it is. It can be anything really. This can be tracked back to parental influence, like almost all of these things can. Perfectionism is really big in eating disorders. I think it's probably obvious why, whatever your ideal is, you want to be perfect at your ideal. And you're gonna do kind of whatever you have to pursue your ideal. Challenges in managing emotions, sort of like obsessive compulsive disorder, where you don't really have a lot of tools to manage your feelings. Same kind of idea. These people go towards food, or rather away from food or whatever it is, rather than to any other obsessive or compulsive behavior. But really, a lot of times there's a lot of overlap between these two things, and a lot of people with eating disorders also have OCD because a lot of it is the same stuff, right? Um, so history of childhood trauma or major stressors, challenges with control in general. So, these are folks who are either very low in being able to control themselves, so that's an impulse control problem, or they're really seeking to control the environment the best that they can, you know. So these things are in general common to all the eating disorders. Okay, PTSD. So PTSD is triggered by experiencing or witnessing a traumatic event, right? So you don't have to have experienced it yourself, but proximity does matter. So if you're very far away and you witness something, you're less likely to develop PTSD than if it happens right next to you. But everybody is different, right? And we all come to life with different risk factors and different protective factors. And so something that causes PTSD in one person will not cause it in another person, right? So it's very individual in that way. But there's some very easily identified risk factors that make it more likely to happen, and that's a history of trauma, a lack of social support, and pre-existing mental health. So here I really want to talk about the prevalence of PTSD among American military service members. Now, obviously, it's true that they see a lot of traumatic events. They experience a lot of traumatic events. And so, on that front, sure, they have a higher rate of PTSD than the general population. But once you control for that, they still have a higher rate of PTSD than the general population. And if you think about what I bracketed here, which is the risk factors and the resiliency factors, basically, it should be clear with a little bit of thought why that is the case. So in the United States, the people who have a tendency to volunteer for military service have a tendency to, by and large, come from less advantaged backgrounds than people who don't, right? So these are the folks who are more likely to see the military as an option to get a head start in the world, get a leg up in the world when they come from a background where it's not easy to do that. So they sometimes will come from places where there's a lot of trauma, there's not a lot of social support, there's a lot of mental health that they're struggling with, or that their family members are struggling with, or that there's a really strong family history of mental health disorders. And the reality of the situation is that anytime that you pull from a population that has less economic advantage, you're going to end up with a population with a higher set of risk factors. So therefore, you're going to end up with a population who later develop higher rates of PTSD. All right. So that's another way that we can think through the social determinants of health, right? So the symptoms around PTSD, they're in your book, and I think we all have a kind of instinctual understanding of what the symptoms are. But the ones that I really want to highlight here are the last two, the negative changes in mood and cognition and hyperarousal, because these are the ones that are more noticeable, right? The intrusive thoughts and the avoidance is more of an internal state to the person who has PTSD, where these other symptoms are external. And so these are the ones that are more likely to catch the notice of somebody. But because so many of the symptoms are internal, it can actually be quite easy to miss PTSD. Right. And then you end up with a whole host of knock-on effects from that, not the least of which is a pretty high suicide rate among former military folk. Okay. Dissociative disorders. So um, I'm going to give you a second, just pause the video and have a read through what Dr. Raisin said here. I think it's really powerful. Okay. So hopefully you had a chance to read that through. So dissociative disorders in general are pretty controversial, but I really like the way that Dr. Brazen thought this one through, which is that whether or not they, exist in the same way that, bipolar disorder exists, since that's our example of the evening, right? Um, whether or not it exists in that way is almost beside the point, because people who have these symptoms invariably are coming to, the attention of the mental health professionals because their distress is so great. Their trauma histories are so deep that, whether this is a psychological process where the mind completely splits off, and this is a true thing where there's different personalities and they're completely shut away from each other, versus a coping mechanism by somebody who has experienced an extremely serious trauma. Like, does it really matter at that point, right? Like, the bottom line is the same, that this person has experienced crippling trauma, and this is the only way that they can think of to get through it, right? This is the only way that they can come up with to cope. So, I found that to be a very useful perspective. It's a very useful way to build empathy for folks who are living with a disorder that you may or may not believe in. Oops, it's the wrong way. Right. So I do want to point out that dissociation itself is very real, and it is also very adaptive. So dissociation is something we all do. If you have ever zoned out and driven somewhere that you did not intend to drive, or gone past your exit and been like, wait, what's going on? Because you were just somewhere else in your head, you dissociated, right? It's not a complicated concept. And so in moderation, it's actually fine. It's kind of relaxing sometimes. But it's normal. It's just, as with many things, when it kind of runs away and goes off to the extreme, that's when it becomes problematic. Okay, schizophrenia. So the DSM-5 removed the subtypes of schizophrenia. which is fine. It kind of makes things a little simpler. And the bottom line of schizophrenia is that you need to have one or more of, these symptoms. But the two cores that we are used to seeing in schizophrenia are delusions and hallucinations. Disorganized speech is a little harder to pin down for a number of reasons. But you know, I've never met anybody who was diagnosed with schizophrenia who didn't have delusions or hallucinations or both and only had disorganized speech. Those folks tend to be people who are, for example, coming down from drug use or something like that. So anyway, delusions are tricky. Delusions are thought processes, and they can sort of closely parallel what is possible in life. So when I was in graduate school, basically my first day of graduate school, the professor said, before you label somebody as delusional, you'd better make very sure that their neighbor is not stealing their mail, right? So the reference there is that there's a very common delusion that the neighbor is stealing your mail. But some of them can be so close to reality that we run the risk of accusing somebody of having a mental health disorder when actually they don't. That's actually a thing that's going on, that they're suffering from. So, we have to be very careful about that. Hallucinations are different. They're something that you experience as one of or more than one of your senses. So there's something that you see or hear or touch or smell or, So hallucinations can be really devastating, right? In schizophrenia, hallucinations tend to be auditory, but they can be visual as well. They can be anything in terms of your senses, but the auditory hallucinations do tend to be pretty mean, right? The voices that you hear tend to be pretty awful. So, it's a difficult disease. So I put on this slide that early intervention programs are extremely important and they can stop this from happening at all, which is definitely true. In some cases, if you intervene early enough when psychotic symptoms are just starting to develop, you can stop the process. I'm not saying that you can do that in every case, you can't. There are some cases of developing schizophrenia where it's going to develop no matter what you do. But early intervention programs, even if they don't stop the development of the disease completely, they certainly can keep it from getting as severe as it would have if it was allowed to develop unfettered. So, how does the schizophrenic brain work? So there's part of what makes schizophrenia so devastating is that there are problems in both the gray matter and the white matter. And the problem with that is that that's your entire brain, right? So pretty much no aspect of the person is unaffected in schizophrenia because your entire brain is impacted by schizophrenia. So the biological basis is quite well understood. Basically, the schizophrenic brain has excess dopamine in the prefrontal cortex. Glutamate also plays a role, but we really think much more about dopamine. The reason why schizophrenia is not usually diagnosed after your mid-20s is because the prefrontal cortex is done developing after your mid-20s. And if you are going to develop schizophrenia, it is usually going to happen during this young adult period where your prefrontal cortex is still developing. We've discussed previously that medications that decrease dopamine do decrease symptoms, but if you give too much of it, you're going to end up giving that person Parkinsonian symptoms instead. And, the opposite is also true. So, you over medicate somebody with Parkinson's and you end up with something that looks a little bit like schizophrenia. So you need to be a little careful in both directions. Okay, so this is a really interesting slide. I know it doesn't look interesting yet, but it's about to. So the bottom line is the more DNA you share, the greater the risk you have of developing schizophrenia. If you are somebody with no family history of schizophrenia, your risk is like 1% or something like that, right? And again, once your young adulthood is over, you pretty much have no risk. And so, if you're a 35-year-old person and there's nobody in your family with schizophrenia, you're good. That's not going to happen for you. But things get really tricky here when you look at the bar chart. So there's two interesting things on this bar chart I want to point out to you. So, in a sibling, the percentage risk is, I don't know, we're kind of eyeballing it here, about 6% maybe, I'm not sure. But what is clear is that the fraternal twin, which by the way is exactly the same, shared DNA percentage, the risk is much higher. And, if you think about why that is, the only real difference between these two conditions is the womb, right? The fraternal twins share the environment of the womb. So there is some factor here that has to do with pregnancy, right? There's another one that was pointed out to me by my students in the in-person class, which is the child with one parent of schizophrenia and the children with two parents of schizophrenia. Again, that difference is much bigger than you would expect it to be, right? If this was really about how much DNA you shared and only about that, then it would be exactly twice, right? Two parents would be twice as much as one parent, but it's not. Right? You can see it's much, much higher. And I think the reason for that is, again, environment, right? So if you are a child in an environment where one person is severely mentally ill, your chances of developing that mental illness are not small, but they're much smaller than if you are in an environment where both adults in the home have schizophrenia. Right. So I think that's probably what this difference is about. It's not, if you were just going to talk about, and I would be interested to see the adoption studies on this, but you would expect to see that it would be about double, right? To have two parents with schizophrenia, your risk would be about what is that? 22% would be what you would expect, 20, 22, 23, whatever it is. That's what you would expect. And so if you look at an adoption study where you're raised away from your parents, is the risk about that? Or is it closer to this 40-something%? I don't know. I would be interested to read that. All right, autism. So the thing that I really want to emphasize about autism is first of all, it has different severity levels. Diagnosis is quite early. And I really want to talk about ABA. So we're going to talk about applied behavioral analysis more when we talk about therapy, most likely. But, I just want to emphasize that ABA is a controversial therapeutic intervention based in behavioral techniques. Think the rats with the levers and all of that. And it does work, but the objections are around the humanity of using it because it's not always pleasant. It's not pleasant to watch. It's not pleasant to experience. And, the folks who are against ABA think that it is abusive, right? And the people on the other side say, well, if it wasn't for ABA, my child would not be nearly as functional as they are. And so, there are people on both sides of this argument that have good points. And it kind of depends on what your philosophical point of view is, right? Like, is it more important that the child is, happy and unfettered, or is it more important that they do a little bit of suffering or a lot of suffering in some cases in order to have a more successful life outcome? And the decision on that lays pretty much solely with the parents. So we just have to, give people a little bit of grace on both sides of this argument because it is a very difficult spot to be in. It truly is a very, very difficult place because there really is no decision that you can make that is both 100% humane and 100% the most that you can do to help your kid. So it's super tricky, right? It's super tricky. All right. So here's a video that we are not going to watch in the context of this lecture, but it's in Canvas for you to watch. It's really helpful for folks with ADHD. I think we pretty much all know what ADHD is. And this video it's interesting if you don't have ADHD. And if you do have ADHD, it's pretty helpful. So go now and watch that video. It's on Canvas right behind this lecture. All right. Thank you so much, everybody. I will see you next time. Thank you.